We don't hear you now.
Do you hear me?
Yes, okay.
Okay. I'll start my video. Okay, good afternoon, everyone. Please excuse me, but I will talk in English. I think it's more convenient for me. I'm Pieter de Cock. I'm a hospital pharmacist, clinical pharmacologist at the Gent University Hospital. I'm very delighted to have this talk here on augmented renal clearance, myth or reality. So I would like to thank the organizing committee to invite me. I have nothing to disclose besides that I'm from Belgium. In Belgium, we have two famous statutes, a boy and a girl peeing, manneken and janneke piss. So maybe in Belgium, we are a little bit more predisposed to do some research on augmented renal clearance. Now, what's the definition of ARC, the abbreviation ARC, augmented renal clearance? It's an enhanced renal elimination of circulating solutes compared to baseline. It's a quite common phenomenon, especially on the ICU units, and I will focus my presentation on augmented renal clearance on the ICU units, with a range of 20 to 65% of prevalence in adults, an even broader range in critically ill children, a range of around 8 to 78%. This broad range, or this broad range, actually relates to the different thresholds that are being used. The most commonly used threshold in adults is a GFR, the glomerular filtration rate of above 130 mL per minute per 1.73 meters square, but also more stringent thresholds are being used above 150. Even more heterogeneous in children, same values of thresholds of above 130, but also a lot of numbers being used, even up to 250 mL per minute per 1.73 meters square. We are more in our hospital in favor of using age standardized definitions, and we use the GFR for age plus 2 standard deviations. We all know, you may know, that there is a maturation in GFR up to the age of around 2 years. So we thought it was most plausible, especially to study ARC in the more younger patient population, to have an age-changing threshold. Also, clearances of renally cleared drugs, like the clearance of vancomycin or the clearance of aminoglycosides, only exclusively eliminated by GFR, have been used to describe augmented renal clearance in children with a threshold of 130 mL per minute. The broad range also relates to the differences in estimation or measurement methods for GFR in adults, the measured creatinine clearance being the most commonly used method to actually estimate GFR, but also other estimation formula, CKD-EPI formula, MDRD formula, Cockcroft and Gold formula, and the measurement of UXL, the clearance of measurements of UXL have been reported. In children, the Swartz formula as estimation for GFR has been used most commonly, but as said, drug clearances, UXL clearance, and measured creatinine clearance have also been used. The Swartz formula is a very easy to use formula. It's based on creatinine, serum creatinine. It's an estimation method, but we think it's not that ideal to actually identify patients with real augmented renal clearance. It's a cheap biomarker, but the formula is only validated in children with a normal renal function up to children with chronic kidney disease. And that's why we performed in our pediatric and neonatal ICU units an interventional study in which we measured actually as golden standard UXL clearances, and we compared them to the different estimation methods. And we used different biomarkers. We used creatinine, cysteine C, beta-trace protein, and we used a combination of biomarkers in combination formula. And we also used the urinary creatinine clearance as estimation methods. We set as a threshold for accuracy a threshold of the P30 above 75%, meaning that 75% of patients should have an estimated clearance within 30% deviation from the measured UXL clearance, as I said, being the golden standard. And what you can see here is that the most commonly used Schwarz formula is actually not having an accuracy that is high enough to say that it's a good way of identifying children with augmented renal clearance. Actually, we're currently looking to the feasibility of using UXL clearance as a more routine method to be used in our ICU units. It's feasible. It has no safety issues. In our around 100% of children, we actually used it in. And yeah, we're currently developing together with colleagues from the lab actually a method in which we only will use 1 drop of blood actually to measure the UXL. Now, with regard to risk factors, most commonly cited risk factors in adults, critically ill adults, are adults with a young age, with a poly or needle trauma, with lower severity illness scores, with burns, with hematological malignancies. In children, risk factors that have been cited, age above around 8 years of age, serum creatinine below 0.9, male gender, children with sepsis, use of antibiotics, febrile neutropenia, and the absence of vasopressors. Regarding the time course of this phenomenon, in adults, we see that this phenomenon lasts for multiple days after ICU admission. This is the slide for the adult population, ICU population, with the solid bars being patients or the proportion of patients with ARC. It lasts for multiple days, and a similar phenomenon being described for critically ill children. Very interesting study from the colleagues from the KU Leuven, the University of Leuven in Belgium, on the adult ICU unit. They developed an IRC predictor to forecast the chance of having a patient with IRC on the following day, using some predictors like gender, like age, trauma, cardiac surgery, yes or no, day from ICU admission, and serum creatinine, which is in the case you don't have access to more complicated or to a lab performing TDM, for instance. When we talk about dose adjustment in those patients, it can be an accurate way of estimating whether you should use higher doses. Coming back to the actuality, our ICU units are overwhelmed currently, especially in Belgium. We're doing the worst, I think, in Europe for these days. Patients with COVID, do they present with IRC? COVID patients are more prone to the development of acute kidney injury, but from our own adult ICU units, also some patients can develop augmented renal clearance. The proportion is lower than in the general mixed ICU population, but be aware that also this type of patients can develop augmented renal clearance. Regarding pathophysiology, there are a couple of hypotheses being proposed. The most commonly cited is the one in the middle, where we have a systemic inflammatory response syndrome with a cause of burn, surgery, infection, leading to vasodilatation, to an increase of cardiac output, leading both to an increase of renal blood flow, leading to an increased filtration, and leading to augmented renal clearance. It can be exacerbated by an aggressive fluid suppletion. The use of vasoactive medication could also exacerbate the impact and the effect of augmented renal clearance. Another hypothesis is the development or the existence of the renal function reserve. It's kind of the intrinsic capacity to augment the glomerular filtration rate to physiological stimuli or pathophysiological stimuli. It relates to the risk factor of younger patients being more prone to the development of ARC, because younger patients more commonly have an uncompromised renal function, as for instance, the youngest ones, the children. That's another hypothesis, and especially for then the traumatic brain injury patients, a disturbance between the brain-kidney crosstalk leading to an altered clearance could also be a potential mechanism regarding pathophysiology. Now, previously, the phenomenon was described as more commonly not using the term augmented renal clearance, but hyperfiltration. But this is only a matter of filtration. We all know that renal clearance is actually the sum of what is filtered, what is secreted in tubuli, minus what is reabsorbed. And in this context, this study from Matthew Udy in Critical Care in 2014 is really interesting. Actually, they studied the mechanisms underlying this augmented renal clearance. Is only GFR involved, or also tubular secretion, reabsorption, and so on? What they actually did, they administered an IV cocktail of probe drugs, sinistrin for measuring GFR, para-aminopuric acid for measuring the plasma flow and anion secretion. They administered pindolol for measuring the cation secretion in the tubuli, and they administered fluconazole for measuring or estimating tubular reabsorption. And what I actually saw that indeed GFR was increased, the renal plasma flow was increased as compared to healthy volunteers. Anion secretion, as also estimated by the para-aminopuric acid, was increased, but the cation secretion was lower as compared to healthy volunteers, which was a kind of unexpected finding, which there were only, they didn't have a clear explanation of this, besides that maybe pH changes could have an impact on the activity of the tubular transporters, together with some unknown drug-drug interactions at that level. Also, reabsorption of fluconazole was increased as compared to healthy volunteers. Another unexpected finding, but maybe also an interesting one, that there was an increased non-renal clearance as well of some compounds. So maybe augmented renal clearance is combined with maybe an increased liver clearance as well. It's the only report I read on this, but it's rather interesting finding. Of course, this type of study, administering a cocktail of probe drugs, is not, you cannot do this in critical children. So that's why we looked together with our colleagues from the Faculty of Veterinary Medicine if we could use an animal model actually to study the excretion processes and what is going on during augmented renal clearance. And what they did, they developed a porcine augmented renal clearance model using endotoxins. But whenever they were developing this, they had again, an unexpected finding that in the control group, there was also an increase of GFR, not only in the treatment group receiving then the toxins, but also in the group that only received fluid suppletion. So that led us, in fact, to another study in which we wanted to study the impact of fluid suppletion on the development of augmented fluids. We used piglets. Our research is focused on pediatrics, so we used piglets because there's a lot of similarity between the kidneys of pigs and humans. This animal model has been proposed to study drug PK in drug development for humans, especially when we're talking about renally cleared drugs. So what we did, we had a control group receiving no fluid therapy. The pigs could drink, but they didn't have an intravenous fluid line. And we had a treatment group treated for 36 hours. We administered them UXL at baseline and after receiving fluid therapy to measure GFR, para-aminopuric acid to measure the plasma flow, the effective renal plasma flow, and amikacin as a kind of model drug in a quite low dose in order to see whether whenever ARC was developing, there was also an impact on drug disposition. These are the results where you can see significant impact indeed, as we thought, on the clearance of UXL, so an increase of GFR, going together with an increase of plasma flow as expressed by the clearance of para-aminopuric acid, having an impact on drug disposition with a lower AUC, the area under the concentration time curve of amikacin. Amikacin being a renally cleared drug exclusively by glomerular filtration, and an increase of clearance of amikacin. We think, this is our hypothesis, we also thought that in our youngest children, why would we see there a child with augmented renal clearance? I think this is maybe even more important compared to adults in the impact of fluid suppletion. We give a lot of drugs on our ICU unit. They all have to be diluted in a certain volume. So it's not like neglectable, and we should also focus on fluid restrictions, especially when we think of developing or the risk of developing ARC. So the effect on drug pharmacokinetics is quite evident, especially for renally cleared drugs. There's an increased clearance that is plausible. In some papers, they also talk about a higher volume of distribution. I think this is something, more related to the pathology itself, maybe an increased capillary permeability, increased clearance leading to a lower area under the concentration time curve, shorter elimination life. Important to say that these phenomena are only studied using plasma concentration data. We don't know yet what's the exact impact or the magnitude of impact on tissue PK, the target tissue of interest, but that there will be an impact that's plausible. Most commonly studied, the impact of that altered PK on target attainment are the antibiotics. We have three types of antibiotics. We have time-dependent antibiotics, where the time during which the unbound concentration of the antibiotic above the minimal inhibitory concentration is a target of interest. We have concentration-dependent antibiotic, like the aminoglycosides, for instance. They have Cmax over MIC ratio that is the target of interest, and we have the mixed combination, the area under the curve over MIC combination. I think one of the previous speakers, focused on optimization of antibiotics. So have an impact on all these three types of antibiotics, and as a kind of illustration, this is a study we performed in 2015, where we actually studied the pharmacokinetics of amoxiclav in critically ill children at our unit, children between 1 month to 15 years of age. And unexpectedly, we had a very high clearance, a typical clearance of, if we standardize this to an adult person of 70 kilograms, a clearance of 18 liters per hour, which is even much higher. That was described on our adult ICU unit. Adults with augmented renal clearance with a typical clearance of 10 liters per hour. So an unexpected find in the first report on augmented renal clearance. We used cysteine C as a renal biomarker. We were not able to check serum creatinine actually, but this as a side remark, cysteine C being more and more also used as renal biomarker to describe renal function. In this paper, we also identified the impact of the use of vasopressors. When a child was on vasopressor, there was, I think, an 80% decreased clearance. So we think this is a kind of how would I say it? A kind of proxy for saying or to illustrate or to measure the disease severity of the child. When a child is on vasopressors, I think this is a proxy for a more severely ill child when compared when the child is not on vasopressors. Whether this had an impact on probability of target attainment, this illustrates this slide with on the y-axis the probability of target attainment versus the MIC, the minimal inner target concentration. We used a very conservative target of time above MIC at that time of only 40%, which is really conservative. An MIC, which is a kind of worst case scenario for Escherichia coli of 8 milligrams per liter, and a probability of target attainment set at 90%. And in the best case scenario, where we had a cysteine C level of 1.2, reflecting a child with a more or less normal renal function, even slightly diminished renal function, we only had a PTA of around 40%, with patients with augmented renal clearance having a very low probability of target attainment. So it has a clear impact on target attainment, and it's mostly described for antibiotics. More and more other classes of renally clear drugs and the impact of ARC on target attainment become available. This is just a paper published in, I think, 2021. It's not indicated on the slide, but where it was shown that with the licensed dose to use for levetiracetam, which is an antiepileptic drug, they had a very marginal target attainment, and that you actually need to prescribe off-label, to use an off-label dosing regimen in order to reach that preset targets. Yeah, more or less similar for enoxaparin, low molecular weight heparin, with patients with low serum creatinine levels needing higher dosing regimens than described in the summary of characteristics. The link with target attainment is clear. The link of ARC when using standard dosing regimens on clinical outcome is scarce and conflicting. Some papers describe more therapeutic failure in patients with IRC when using standard dosing regimens when compared to non-IRC patients, while others don't. There's, as I say, a number of papers. I think from France there are also 1 or 2 papers, but yeah, it's conflicting evidence, and it illustrates the complexity of treating ICU patients with a lot of course, comorbidities and a lot of other confounding factors. I will go quickly over the dose optimization strategies. I think Magdi and some other speakers may have touch upon this. To my opinion, there are kind of 3-level approaches. The first level approach where you actually use a mathematical model to optimize the dosing regimen for the overall population. Use PK/PD modeling. Maybe you stratify on 1 or 2 patient covariates like renal function, like age or like weight. But in general, you optimize the dosing regimen for the overall population. On level 2, you perform therapeutic drug monitoring, you perform drug measurements or biomarker measurements, like for enoxaparin anti-10A factor. And you can individualize the treatment for that particular patient in front of you using a dose adjustment algorithm. And where you can account, I heard the last discussion briefly going on with MACD, where the intra-patient variability you can account for using the TDM samples. A combination of level 1 and 2 is the model-informed precision dosing. Magdi also talked upon this, where you actually use dose calculators based within the background to mathematical models, and in the end also TDM samples to give extra information to the calculator in order to further fine-tune the dosing regimen. Coming back to the example with a level 1 intervention, the example of amoxiclav, what we actually did in our patient population nowadays, we use a dosing regimen of 25 milligrams per kilogram, but not anymore the dosing regimen which I showed you the probability of target attainment for. This is a dosing regimen that was at that time, I don't know anymore what is still the case, but at that time mentioned in the British National Formula for Children, so quite commonly used formula where they used a Q12-hour dosing regimen for children less than 3 months and Q8 hourly dosing for children older than 3 months of age. We currently use a 4-hourly dosing regimen infused over 1 hour infusion duration whenever it's a patient identified or presumably infected with Enterobacterialis. And you see that the probability of target attainment for that overall population is extremely well. TDM, we have traditionally, since decades, we perform TDM for especially antibiotics, glycopeptides, aminoglycosides. New kid on the block is the TDM for beta-lactam antibiotics. There's still some hurdles to take. There's a lack of knowledge on which specific target value we have to aim for, and also the availability of assays in the routine labs hamper its routine implementation in the clinic. This is a survey in the British Journal of Clinical Pharmacology 2021, where they actually surveyed all Australian hospitals, and you see that the implementation is not yet your routine practice, this type of dose optimization practice. I heard Magdi talking, so I will go briefly over model-informed precision dosing. We can perform a priori predictions using the model, some patient covariates in order to model to predict the starting dose, and we can a posteriori predictions to further fine-tune dosing regimen. Really specifically, with regard to ARC patients, we have to have fit-for-purpose model. And I think some of the discussion was also going on this specific thing. You should, whenever in the model you use, there are no patients with RC being used during model development. There's a high chance that the model will have a high bias and a high imprecision. It will not give you any added value to use in comparison to the level 2 or level 1 intervention. So a fit-for-purpose model is really key. I think more MEPD is the way forward. I think with a lot of optimization going on in the clinic. This will be something to look for in the future. There are some challenges to take, like regulatory aspects, like practical aspects, but I think this is the way forward. To end, I focused on ICU populations, but please be aware that also hyperfiltration, augmented renal clearance have been described in other patient populations. To summarize, ARC is common in ICU adults and children, but also has been described in other patient populations. It's better to talk about augmented renal clearance instead of hyperfiltration, because tubular secretion and reabsorption are also involved. There's a clear impact on target attainment and dose requirements of renally cleared drugs. The impact, however, of ARC using standard dosing regimens on clinical outcome, there's still conflicting evidence, and we need to study or to have more studies on this in order to understate the current dosing optimization strategies we already perform, and also further studies required regarding pathophysiology and appropriate biomarkers to actually identify patients at risk of RC development. And with that, this is my acknowledgement slides. I want to thank you for your attention, and happy to answer any question.
Thank you very much, Peter, for this very good presentation. Have some questions?
Yes, thank you. Can you do some modifications of the protein binding have been reported with renal clearance?
If I understand the question well, have there been protein binding changes being reported with relation to patients with augmented renal clearance? I'm not aware of alterations in protein binding, plasma protein binding, specifically in patients with augmented renal clearance, or whether there is a difference in between patients with augmented renal clearance and not identified with augmented renal clearance. I'm not aware of that. In general, altered protein binding has been described in patients on the ICU unit and in younger children, especially, for instance, for vancomycin. There are some reports on change of protein binding, and it's only a drug which is moderately protein bound. But I don't know, I don't think there's a specific report on in relation to augmented renal clearance, no.
Thank you.
This will, of course, be something in relation to the finding of augmented renal clearance together with an increase in volume of distribution. Could be some, I don't know whether these are related to each other, but it could be the two phenomena are actually happening in ICU patients, and this could be a plausible explanation for the increase in volume of distribution.
Thank you. Your questions?
I have one question. Thank you, Peter. It's maybe a very nice talk. So, which method to estimate the GFR do you suggest to our clinician, just to estimate daily the renal function? We understood that there are many methods to estimate the GFR, but none of these methods is accurate. But we need maybe the best surrogate of GFR.
Yeah, as you can see, we tested, I think, 26 or 27 formula or estimation methods, and we set our threshold at 75%. Yeah, and not any estimation method actually hits that It's that threshold. So, as I said, we are currently looking to see whether, if we want to really have an accurate GFR estimation or measurements to implement in routine practice the UXL clearance. It has been suggested for adults too, but especially in children, because there's such a bad result of all those formula that that currently measuring UXL clearance is the best method. Of course, you have to have that assay available in your lab, and you administer an exogenous compound to your patients, so you have to have a good rationale to do it. But whenever you want to have the most accurate estimation, it's feasible to measure UXL in the clinic.
Thank you very much.